and welcome to our antenatal class. My name's Rosie and I'm midwife on the Haven Birth Suite and also Central Delivery Suite.
And my name's Jane. I work on the postnatal ward but also on Central Delivery Suite as a midwife as well.
So today we're going to talk to you about some of the things that can take your birth plan a little bit off kilter. We're also going to cover what this means for you, your options and your birth preferences, and we're going to go into a little bit of detail about an assisted birth and also caesarean sections and making the most of a plan B.
But first of all, I want you to think about your birth. And we talk about birth plans, but I think in an ideal world, we really would prefer you to talk about your birth preferences. So when planning your birth, start with a piece of paper where at the top you write the title Birth Preferences. We're going to go through all the reasons for this and how even just this one small thing at the start of your preparation for birth will help you to get the most positive experience.
When it comes to planning the birth of your baby, you should absolutely reach for the moon, but consider the stars. All women ultimately want a healthy baby from their birth, and all midwives share this goal with you. But a healthy baby shouldn't be all you can hope for. That's just the baseline. You come with your own experiences, preferences and hopes, and you absolutely should consider what a positive birth looks like for you. At the same time, a birth plan is just as much about considering your preferences and options if your plan A goes a little off course. Life is unpredictable and birth is certainly no exception. So today we'll talk about how to navigate the unpredictable nature of birth. We'll highlight some common obstacles and explain how you can keep hold of the elements of your plan, make informed choices about your potential changes in directions, and hopefully enable you to feel more prepared for positive experience no matter what path your birth takes. Here are just a few sample of things that can cause your birth to go a bit off course, or just some common things that we know that women worry about. Have you considered any of these questions? Maybe you've got your own questions to discuss with your community midwife.
As midwives working in the hospital, we can anticipate some of your concerns, but we're never shocked by the questions we get asked. One of our main roles in your birth experience is to advocate for you. We are your voice in an unfamiliar environment with unfamiliar faces and unfamiliar terms being used. But we know how the systems work and we can help you through this amazing time in your life. So please, please use us as your midwife and that voice. We are your person and we will always have yours and your baby's best interests at heart. Okay, Rosie, so let's talk about a scenario where perhaps plan A turns to plan B.
Okay, so imagine that we are on the Haven. I'm caring for a woman, it's her first baby. She's coming contracting spontaneously, she's doing it all by herself, she's doing really well. She's coping amazingly in the pool, and these contractions are getting kind of quite regular and a bit more intense. And she's starting to think about other sort of pain relief options. She's been using the aromatherapy and that's all gone really well. And things are just picking up a little bit when her waters go. And you can have a look in the pool and it's like a pea green soup.
As midwives, we know what that means, but it could
For the
initiate
woman,
a little bit of a change of plan, couldn't it?
Yeah, so basically what we're looking at when the waters go is that the colour of them. So if they're clear, sort of straw-like colour, or even a bit pinky, that's all good. But if they've turned into that sort of tinged with green, what we have to think is that baby's probably done a bit of a poo inside. And that does change plans ever so slightly. So what would you think the next step would be if we'd had meconium, so the baby don't poo inside?
So we'd be having a conversation really about the safety of mum and baby, that realistically, instead of listening into baby's heart rate every 15 minutes or so while you're in the water, we'd probably want to be continuously monitoring baby's heartbeat.
You can still do that in the pool?
We do have the ability to do that in the pool, but the fact that there's meconium there now has slightly changed that plan. So probably the safest place to be would be a transfer to delivery suite. Now, in our hospital, that's a really short journey.
Yeah.
And I think in your head, you probably think that that would be quite traumatic. But we'd assist you out at the pool, get you nice and dry, get you all nice and covered up and warm, and move you, baby, and your birth partner over to the delivery suite. We have got a short video actually that we'd quite like you to have a look at, just showing that transfer over. It's not from a pool, it is from a birthing ball point of view, but moving over into a delivery suite room. So it's probably worth a quick look at that now. It's time to go now, so I'm going to go over to the delivery suite. I'm just going to help you up onto the wheelchair, all right?
Okay.
So let me just help you over to the chair. Well done, well done. Okay, sit down, sit down. Okay, are you okay there?
Yeah.
All right, okay, so just keep taking those nice deep breaths. We're going to just move over to the delivery suite now. All right, well done, we won't be long. So we're just going to go see these double doors here. We're just going to go through here. Bear with me a second, all right. Excellent. Here we go. All right, keep taking those nice deep breaths. Right, I'm just going to go backwards for a moment, just so it's easy to get through into the delivery suite. If you look just behind you, you can see the doors to delivery suite. There we are. All right. Excellent. I think we've got a nice room empty for you. All right, here we go. Just coming through now. Just coming through. Thank you. All right, well done, well done. You're doing really well. I'm just going to go straight along here now. Excellent. And this is our room here, just on the right. Well done. There we go. All right, so we've still got things like a birthing ball in here. All right, and you've got an ensuite just over here. Let me show you where your ensuite is. You've got an ensuite here too, just like you did at the Haven. All right, there we go. Well done, well done. All right, now do you want to be on the bed, or would you like the birthing ball back again?
I'll have the ball, please.
All right, well done. Okay, so you've had a chance to see what the delivery suite rooms are like, and they're quite large and spacious. But from the woman's perspective, and you as her midwife may well have moved over with her, what kind of questions are you likely to be asked at this point?
Okay, so a really common one, because obviously beforehand she was using the pool to cope with the sort of contractions. Main one is, can I still be in the pool?
Unfortunately, due to there now being meconium, we'd really want to be carefully monitoring the quantity and the colour of that meconium. In a birthing pool, that's really difficult to do because it's such a large quantity of water that you're sat in whilst labouring in water, that actually it dilutes very quickly any changes in that meconium. So we're able to monitor things and the well-being of baby a little bit more closely by being out of the water,
Okay.
unfortunately.
So the next one would probably be, does that mean I just have to be sat on a bed?
Well, all the delivery suite rooms have beds, as do the Haven rooms, but in delivery suite as well, no, you don't have to be on a bed. We've got birthing balls, we've got lovely big gym mats that can be used so that you can be kneeling. The bed adjusts to different heights, so one of the positions that I quite like is sat on a birthing ball but with the bed quite high so that you can bounce but lean on the bed. I think as well the fact that you will want times of rest during your labour, but that doesn't mean lying stationary and kind of strapped to a bed. Our wireless monitoring means that you can still get up, still move around, try different positions, kneel over the back of the bed, and actually if you do want to rest, if you do want to try and get that proper rest between your contractions, being able to sit or lie on the bed is still an option for you, but the bed can go into a lovely kind of throne position. I like a throne position.
And I think the other worry is that you've just got the atmosphere all right. You've come into this room, it feels like your safe place. You've got the lights dimly lit. You might have little electric candles going, and it just feels like calm. And the worry is that if you go to another room, that all goes out the window. So is that necessarily the case?
Absolutely not. The transfer, obviously, you're going to be wheeled along a small area of corridor, which does need to be brightly lit. But once back in the room, you're perfect. And we'd love you to ask your midwife, if they don't remember to do it themselves, that we love you to be able to say, is there any chance we can have the lights more dimmed? We've got dimmers on the lights. We can. There's quite often lamps or low-level lighting that we can put in the rooms for you. You can have music playing. We've got radios in many of the rooms anyway, but if you want to bring your own music, then bring
They've
that.
got CDs on there, haven't they? We have to go old school.
We have got some
They're
CD
all
players,
CD players,
yeah. But that doesn't mean you have to suddenly dig out your 1990s CDs.
I don't know.
We can have the radio on, or if you can even bring a small speaker and your phone and your charger. We can do all of that so that you can have your own music, your own choice playing. And quite often that can be enough to just get you back in that zone. Very often, the midwife who's been with you on the low risk area will transfer with you where possible, but otherwise we always match you up with someone who can give you, everyone's going to give you the most lovely care anyway.
Yeah. I think when you're in labour, it's quite normal to become a little bit obsessed with how dilated you are, how quickly things are moving along, and the big kind of grand finale can be that you're fully dilated and you can start that pushing to meet your baby, and that is a big moment. But it's important to remember that although that sensation might come instinctively and you can't help but push, or you might need a bit of guidance about how to push and make sure that baby's coming down, sometimes it can take a bit of time, and I think it's important to know what a normal time frame is for that to take.
Yeah, and I think we've been probably slightly misled by TV and films really, where they've only got a very short period of time to show a birth in, and
highly edited.
Very edited, especially in movies where your waters go and 3 pushes and the baby's out. That would be like really quite strange for us if that happened, and we probably wouldn't be quite ready for you. Perhaps we'd want gloves
Getting
on
our
at
gloves
least.
on, yeah.
But having said that, a normal time frame, for it to take an hour to push your baby out would be probably on average
usual.
your first baby would take at least an hour to push out. And that's because we want babies to be born slowly and gently, and your body to take that role really gently and in a really automatic way. Sometimes you will want some guidance from your midwife, and sometimes at that point, and maybe after an hour or more, we might be talking about whether you could do with some assistance with birthing your baby.
And there's a few different reasons for that,
Yeah.
isn't it? I suppose the first one we've kind of touched on, which is that maybe you've been pushing for quite some time. Sometimes if it's your first baby, you could be pushing for up to 2 hours.
Yeah.
And as long as baby's totally happy and you've still got that energy, that is absolutely fine. But at other times it can take it out of you and you might just feel exhausted, like you've got nothing else to give.
I think also because we're monitoring baby's heartbeat, and we talk to babies through their heartbeat, or they talk to us more likely really, and they tell us how they're feeling about the whole situation. There are some things that we like to see that are quite normal with baby's heart rate. A dip in the baby's heart rate as they're being squeezed and pushed and then quickly recovering again is absolutely fine.
Yeah.
We're good with that, aren't we? But sometimes baby's heart rate is telling us that actually baby's quite exhausted too.
Yeah.
And at that point we might ask a doctor to come and perhaps review the situation.
Yeah.
What other scenarios might there be?
Sometimes you might have your own pre-existing medical conditions that you kind of come to pregnancy with, so maybe like a cardiac condition where you've had a chat with your consultant or your own specialist and they've recommended that you perhaps only push for half an hour or 30 minutes for an hour or an hour, and that's part of your plan so that you don't put your body under any sort of exertion or excess stress, perhaps.
Yeah, I think also baby's position as well. Again, we rely on baby's natural instincts to be birthed in the best possible way, and that's with baby's head with their chin tucked right down and the bit touching your cervix. We want to be the crown of baby's
So
head.
this bit's obviously the smallest part of Jane's head, and that's the sort of direction that we want it to come down in.
Which was almost like putting on a new polo neck jumper.
Yeah.
I love this analogy. So when I buy a new polo neck jumper, I wouldn't try and put my face through the hole first. That would be stupid.
But it could work.
It could work, but I'd find it would be quite stressful. If I try and put my ear through first, it's again, this diameter of my head that's quite big. I've got quite a big head.
Yeah.
So actually, to pull a jumper over my head, I would probably pull it from the back over.
And you do it instinctively, and most babies will do it
that too.
instinctively, but some
not
get
always.
confused.
Mm.
Yeah.
Sometimes they'll come down with a little bit of the side of their head leading first.
Yeah.
Sometimes with their brow, and sometimes with their entire face leading, with their heads right back like this, obviously the other way up. And in those scenarios, we do have to think about the safety of your baby and actually how that works with the dimensions of your pelvis. A lot of this is all going on inside and you're unaware, and your contractions do as much as possible to get baby in the good polo neck jumper position. But occasionally baby's head position does mean, and also back to back. You've all heard about it.
Yeah.
When we examine your tummy from the outside, we quite like to feel baby's back somewhere at the front. Okay, that's back to front. That's actually the right way. But back to back means that baby's tummy is facing outwards and the spine is curved against the back of your uterus, against the back of your womb. And actually, that can change. The baby can rotate quite well during labour, but it doesn't always happen. And a back-to-back position for first-time mums is actually quite a difficult birthing position.
Yeah.
It's not impossible, but it is going to be more difficult. So we might ask a doctor to come and review and talk about, they might come and talk to you about an assisted birth. So we've got a couple of options, haven't we? Depending on the scenario, really, and depending on the position of your baby.
So say, for example, you have been pushing for quite a while and you're maybe getting a little bit tired. Baby's just there, they're in a really good position. You might need just a bit of assistance by putting a little suction cap on baby's head. That just goes right here and just helps with, while you're pushing, to gently guide baby out at the same time and so the doctor would be helping to kind of guide baby as you push and just give you that extra assistance to bring baby along the birth canal if they're just there.
Yeah, and actually quite often it's only part of baby's head that needs to be born like that. Once baby's head's born, the suction cap's taken off and you birth your baby and that's all lovely. Sometimes the baby can be left with a little bit of a mark on the back of their head, but the majority of the time that heals very, very quickly and babies handle quite well afterwards as far as things like feeding are concerned.
Yeah. The other kind of sort of situation might be that baby's got a bit stuck a bit further up. Maybe they've come down in a bit of a funny angle and they're not kind of progressing down the birth canal at this point. And they're a bit higher up and maybe their position needs to be altered before they can be birthed. So that would probably be a forceps that we'd use.
Forceps, I think a lot of people are quite scared of. I know that when I was pregnant initially and I wasn't a midwife, forceps terrified me because all I could imagine were these huge metal salad tongs, really. And I couldn't understand how a set of salad tongs were going to be opened up and put inside me. Oh, wow. I learned a lot after being a midwife that actually it's two separate metal, they are metal, sorry, but two separate metal spoons, if you like, are just gently placed inside, one at a time, around baby's head, and then that's used to either rotate or to guide baby down as well into a better position. Now, in order to make a little bit more space at baby's exit, it may be suggested that you have an episiotomy.
So basically an episiotomy is when they do a cut down below, so between, basically done at an angle so that the tear does not...
Yeah, well, let's try and explain it so that what we want to avoid is a tear that goes down towards your bottom. So if you imagine that this is the opening that baby's coming out of, this bit of skin here is your perineum, and I'd love to draw a little bum hole here. That would be amazing. And we can see baby's head coming out from here, like this, and pushing against this bit of skin. Sometimes you can get a small tear in this bit of skin here, your perineum. With an assisted birth, or a birth where baby's head's coming, but perhaps we might suggest that you have a little bit of extra space made, that a cut is made to avoid a tear that goes down towards your bottom. A cut's made off at an angle instead. That's all sutured afterwards using local anaesthetic. Local anaesthetic's used before that cut's made as well.
People's main worry,
Yeah.
and understandably, but we are not monsters.
Yeah.
We make sure you've got good pain relief on board before that cut happens, so that you shouldn't feel it as painful, and then you've got plenty of local anaesthetic after for the repair.
Yeah, and actually the healing of that is a really good healing process. We do recommend that midwives check your stitches in your follow-up appointments after you've had your baby. But healing from that actually is normally really, really good.
And also, if you were to have a forceps birth and the baby's position was maybe slightly off, we might actually rather do that in theatre.
Yeah, that leads us into this next bit quite nicely, doesn't it, actually? So, occasionally an assisted birth can be done in the room, but a transfer to theatre might be suggested. Please don't be scared by that. We've got another lovely video coming up that shows that transfer to theatre. And the doctors would talk you through that, and your midwife would stay with you for that as well.
You also get a bonus team all there to look after you, and they'll all introduce themselves in the video.
Lovely. Go through to theatre now, okay? So I just want you to keep your hands in the bed. We're monitoring baby, so don't worry about baby, and we'll be there in just a moment. There'll be quite a lot of people there. So that's it, well done. Excellent. Just keep on breathing nice and deeply, well done. That's it, come on then. Okay, I'll be with you in theatre, all right? So let's just keep going through here. Well done. Okay. Hi, ladies. Hello. Hiya. This is Lucy. I know you're expecting her. Hi, Lucy. Hello. So this is Theatre Lucy. This is Theatre T. Let's just transfer you round. Hang on. Well done. Thank you, Carla. All right. So there's quite a few people here. We've got the doctor. Hi. We've got Louise. She's our scrub nurse today. All right. And then also around here. Do you want to introduce yourself as well?
Hi, I'm Sarah. I'm one of the runners that runs in theatre.
Okay. And then around this side as well.
Hi, I'm Emma. You're anaesthetist today.
Hello. Hi, I'm Sam. I'm the anaesthetic ODP.
All right. So we're going to transfer you onto the other bed. All right. And then we'll sort out your spinal anaesthetic.
So you've been shown our theatre. Whenever you go to theatre, you've always got an anaesthetist there with you, and their main job is to make sure that you are as comfy as possible, whether that's if you're having an assisted birth with like a forceps delivery, or if you're having a caesarean. Our main thing is to make sure that you are comfy and pain-free, and there's two main ways that they can go about that. So it might be that you come to theatre with a really good working epidural, and that can just be topped up, so it's got a little catheter that goes straight into the epidural space, and they can just put some really strong pain relief medication down there, and that makes you feel nice and numb, and that's all really straightforward. Or it might be that you come to theatre and you've just been using gas and air before, and you might need something called a spinal.
So spinal's nice and quick actually. It involves you sitting on the theatre bed. The midwife and the doctors there will assist you into a good position, and a little bit like having an epidural sited, you need to kind of sit in a kind of hunched over position, and the doctor will make a nice sterile area on your back. We'll ask you to have a good feel of your back. We'll ask you to push this bit of your back out like an angry prawn or an angry cat. An angry prawn? An angry cat or a prawn. I like an angry prawn, personally. All prawns are angry, surely. And then they'll clean your back, put a sterile drape on here, and then very quickly, normally it only takes a couple of moments, to just inject into the space in your spine to be able to put some spinal anaesthetic in there. That very quickly makes your legs quite numb. So from this sitting position, they'll suddenly ask you to lie down and get your legs up onto the bed. And your legs will feel completely heavy and warm and strange very, very quickly.
People have described it of like being lowered into like a sort of
A warm
hot
bath.
tub,
Mm.
and all of a sudden just not really feeling that sort of movement in your legs. So we only ask you to move quickly, just so we don't have to move you, really.
Yeah, it's much easier for you to be able to assist
Purely
us with moving your
logistics.
legs. So once we've got you into that position, if you will need quite good, because of the good pain relief, we might suggest having a catheter. That's a urinary catheter, so that's a tube that's put into your bladder.
I won't
using
demonstrate.
No, we won't demonstrate that. Thank goodness for that. But using a sterile technique, and that's because you won't be able to use your legs to be able to get yourself to the toilet after theatre.
I think it's important as well that it's your midwife that will do that for you. So, you've made that really good connection with them. They are your trusted person, and it will be them that is inserting the catheter. So you've got that privacy with your midwife.
Yeah, it's not for everybody to see in theatre. No. It's done in a very kind of what do you call it?
Discreet.
Discreet, that's the word. A really nice discreet way. Yeah.
Okay, so you've got your good pain relief on board, you've had the catheter put in, there'll be some monitoring of your baby just to make sure that they're all happy with everything that's going on. And it's quite a narrow bed, so you might be tilted slightly off to the side, and that feels like you're
going to
roll off, but no one has ever rolled off.
No.
You are actually much more secure, and we're all there by your side. So that
we don't tilt you to 45 degrees, it's not that quite, it's only a small tilt just to take the pressure of baby.
Just as a pre-warning.
Yeah. Drapes are used so that nobody sees anything they're not meant to see. Everything is done in a nice sterile way.
But
the
even
doctors...
that is optional, isn't it? If you wanted to see a little bit more, you could ask to lower the drapes, or if you don't want to see anything, then they are routinely put up quite high. So that is...
Yeah. Certainly for a caesarean section that's the case. For an assisted birth in theatre, we have you almost sitting up actually, so that the pushing has got gravity to help as well. But an assisted birth is one thing that happens in theatre, but actually probably the main reason that you might be transferred to theatre might be for a caesarean section.
So Jane's already mentioned about an elective caesarean section. So that is when you have your caesarean section booked. So it might be for a medical reason, it might be because you've had a caesarean section before, and that's the way that you would like to do this time. Or it might be that something's come up in the pregnancy, like baby's turned bottom first, and you have weighed up the risks and benefits and actually decided that you would prefer to have a caesarean. If that's the case, it will be a date in the diary, you will know when it's happening, and you will come in the morning and you will have already met the midwife, probably that's going to take you down to have your C-section, and it's all done in quite a calm, relaxed fashion. If it isn't a booked C-section, it's automatically referred to as an emergency, and I think that sounds a little bit scary, but there's different categories of what we would consider an emergency C-section. So Jane's going to talk us through what those might mean.
So a category 4 caesarean section is the planned section. That's how your baby was always anticipating to be born. A planned section is a category 4 section. A category 3 caesarean section is still classed as an emergency because it wasn't booked. However, it just means that your baby, for whatever reason, can't be born vaginally. That could be to do with baby's position, it could be to do with progress in labour. There's all sorts of things that could mean a category 3 caesarean section. But the important thing is that what it means realistically is your baby is safe where he or she is, that mum is safe, and that there isn't a huge urgency to be doing that caesarean section. That will be done when it is safe to do so as far as theatres are concerned. A category 2 caesarean section means that there is a reason that your baby needs to be born by caesarean section, and that it does need to be done fairly urgently. In all of these scenarios so far, birth partners will come with you, your midwife will be with you, and we'll facilitate lots of things to do with your birth preferences in theatre
Yeah.
as well.
I think even with a category 2 caesarean section, there is no reason, there isn't the time to discuss with your doctor and your midwife how you would like things done. So if you want to have immediate skin to skin, if
Announce the gender of baby.
yeah, if you want some music played, if you'd like them to lower the drapes, all of those things. Even with a category 2 caesarean section, there is time to have those conversations.
Yeah.
It is not a mad rush that you
No.
might envisage.
If ever it feels like a rush, it's probably more likely that the theatre team are ready and raring to go.
Yeah.
But that shouldn't take away from the fact that you might still want to have those conversations. The most urgent type of caesarean section, which I think everybody would deem as an emergency, would be a category 1 caesarean section. And that means that there is an immediate reason that your baby needs to be born very quickly. And that could be to do with you and your health and your well-being, or it could be to do with how baby's coping. In that scenario, and only in that scenario, would we not take a birth partner with us into theatre.
Yeah.
Your midwife would still accompany you, but your birth partner would be left in the labour room.
And the main reason for that is our absolute priority is the well-being of you and your baby and getting your baby out safely. And if it is the case, we can get your baby born by caesarean section within minutes, and that
in
can
order,
be a bit of a
yeah,
rush.
and in order to do that, actually, a spinal anaesthetic would delay that slightly. So again, a big change would be that we would offer a general anaesthetic instead, whereby you would be put to sleep for the caesarean section. It's a quick turnaround as far as baby being born and as far as getting you back out of that deep sleep,
Yeah.
but it's to get you pain-free very quickly,
Yeah.
so that your birth partner, yourself and your baby are reunited very quickly.
So we wanted to share with you some of our practical tips for a positive birth. Jane's going to kick us off.
Okay, so my first big one is to keep moving. Even with an epidural, we encourage you to change positions, but as much as possible, keep moving. You can have your baby monitored using our telemetry. Now that sounds like something very space age, but actually what it is our baby monitoring, which is completely wireless, which means that you can be on a birthing ball, you can get up and go to the toilet, you can walk around your room, you're not confined and restricted to the area that the bed's in, for example. All the rooms have got beds in, but that doesn't have to be the focal point of where you need to be. It's automatic that you'll go in and want to climb straight on the bed. But actually, if you want the birthing ball, there's one in pretty much every room. If you want to be on a mat, if you want to be kneeling, if you want to change position, we'd love you and we will help you to do that as much as possible.
I think the other one is as well, we spoke about it a bit before, but maybe sometimes your partner might feel a little bit like they're out of the loop and they don't really know how they can help. If they want one kind of task in labour, it is to be the guardian of oxytocin. And what I mean by that is, so oxytocin is the hormone of love, and I think they are totally appropriate person to make sure that you feel that, and the environment is somewhere that feels calm and relaxed, the lights are nice and dim, and that you feel safe. So anything that they can do to achieve that, wherever you are, just make sure that they're thinking about that and think ways to make you feel nice and relaxed.
I think you've probably already gathered from watching our video so far that we've got silly sense of humours. I don't think you can be a midwife without having a very good sense of humour, actually, and we're all quite unshockable. So we love to be able to chat with you if that's what you want, and if you don't, that's fine. We're very good at reading the room.
Yeah.
If you want to bring an iPad or a laptop with stuff downloaded that you like to watch, or a movie that makes you laugh, we love to be able to do that. Or just talk to us. We can really talk. So we would love to help to pass the time more easily for you.
Yeah, I think if you can keep things as normal as possible for as long as possible, then it just takes that pressure off the situation, doesn't it? Keep things nice and light-hearted. The other thing is just to try and be kind to yourself. Most of the things that we've spoken about today that can make a plan A go to plan B to possibly plan C, most of those things are totally outside of your control, and things like baby's position, if they've done a poo inside, you put that all on yourself, but did you really have any power over it? Not necessarily. And ultimately, all you want to do is try and keep your baby safe and do things in the best way possible to make that happen. So go with the flow, but try and be kind to yourself, that actually a lot of these things just happen, and it's how we deal with the next step to keep things as positive and good experience as possible for you. So we're going to go through a few practical tips of how to kind of navigate if things go a bit off course and how you can make those decisions. So let's try this one with a bit of an example. When it comes to your placenta, we will offer you an injection. It's either an oxytocin or a symptometrin injection, which will help to deliver your placenta. We then wait for your placenta to be ready, so when it's separated, and gently pull the placenta by the cord once it's ready to come. This is something called active management of the third stage, or the delivery of your placenta. And it might be that you want to use this BRAIN acronym to kind of guide you through whether that's something that you want to go for. So the benefits: it can help your placenta to be delivered a bit quicker, you don't need to push it out, and the main reason is to minimise blood loss. Are there any risks involved? Some people find that symptometrin especially can make you feel a bit nauseous, a bit sick. Are there any alternatives to this active management? Yes, there are. You can birth your placenta what we call physiologically, which is essentially just waiting until you feel ready to push and you feel that pressure. Go with that and birth your placenta just like you birth your baby, but it's much more soft and squishy. The main thing with this is it can take a little bit longer and that blood loss might be slightly heavier. I think with all decisions in labour, it's important to see what's your intuition telling you. So listen to your instincts, tune into your body, and trust that deep down you know the best course of action for your body. If things have been straightforward and you've given birth to your baby, chances are that nature's going to do exactly what it intends, and you will be able to birth your placenta without any complications. If, however, things have been a bit more complex and you've maybe needed an induction of labour or a hormone drip, it might be that you would prefer to have the injection just to get things over and done with, and also if you've had any sort of assistance with your hormones, it might be beneficial to carry on with that. The last question is a good test of anything that we're offering you, which is, what if we do nothing? So could we just wait and see if blood loss is a problem? And if it's not, then just birth your placenta naturally. And if blood loss became heavier, when would it be acceptable for you to have the injection? So that's just an example of kind of going through different things that we might offer in labour and birth, and having a discussion with your midwife when you can think about the best thing for you. Birthing from your heart. The H is for hormones, so oxytocin is aka the hormone of love and plays a vital role in birthing, bonding and breastfeeding. Its arch nemesis is adrenaline, the hormone associated with fight or flight. So just consider what things you and your partner can do to make you feel loved, safe and secure. Maybe that's lights down, massage, music, and what strategies you have to get you back into this relaxation zone if you notice that adrenaline's getting into the mix. The E is for elements. Just because your birth has gone slightly off course, it doesn't mean you have to abandon all of your hopes and preferences. If you wanted skin to skin, can this still happen? If you don't ask, no one will know what's important to you, and quite often things can still happen with a little imagination. Baby in arms. No matter how your birth goes, make sure your baby comes to you as soon as possible. Even if medical complications mean this isn't immediate, midwives will do their best to reunite you with your baby as soon as possible. Ask for photos to be taken if you'd like, then you can cherish these moments for years to come, even if it feels like a blur at the time. Often parents get their relatives asking about the baby's weight pretty soon after the baby's arrived, but can the weight wait? There's no rush to attempt There's no rush to interrupt these first cuddles, and the wait will still be there, and the same in an hour's time. The R's for resilience. Remember, you're giving birth in a pandemic. You are tougher than you know, and you've already proven that you can overcome everything that's thrown your way. You may not feel strong as your birth plan flies out the window, but you are. Sometimes birth can be difficult or traumatic at times. If you feel this way about your birth, it might be important to talk to somebody. We've got a birth afterthought service available, and if you want the opportunity to talk through the hows and whys that your birth went off course, it's important to make this referral. We've also got a counselling service, so if you just need someone to listen. Always remember that the strength that brought your baby into this world is strong, and draw on it as you move forward through various challenges of motherhood. Allow yourself time. Birth is a massive moment in your life, and you will probably remember many details for the rest of your life. If you lost track of plan A, B or C, you absolutely have the right to feel upset or disappointed. It doesn't mean that you don't appreciate having a healthy baby. Take your time, you matter too.
So in summary, what we'd like to do is reassure you that as much as possible, and however you birth your baby, it's always our aim as well to facilitate as many of your birth preferences as possible. And some of the most common things we'd like to just quickly address now.
Yeah, so I think like skin to skin, I think many mums wonder whether they'll get to hold their baby as soon as possible, and I think every midwife has that same instinct of wanting to get your baby back to you as soon as possible. And no matter how you give birth, whether it's a C-section, water birth, forceps delivery, we still want to bring that baby onto your chest as soon as we can. And things like cutting the cord, I think people think we're in a big rush. We know this is the most important day of your life, and we do take our time to make sure that baby gets that blood back to them. That is standard. The only time that it's ever maybe done in a bit of a quicker time frame is if baby's having any sort of difficulties and we need to take them to the resuscitaire. But 99% of the time, we have that time to make sure baby has all of that blood back to them, and we can just wait.
Yeah, and I think the whole wait for white and everything, our doctors in theatre are more than aware of
The benefits.
Absolutely,
of
yeah,
optimal
yeah.
cord
And they will facilitate that. Even if it isn't something that's particularly come up, they still know that that's the best thing for babies. And announcing the gender of your baby, oh my gosh, it's such a big thing.
It's the best moment ever to watch.
It's amazing. I love it when the baby's head's out and you still don't know what gender the baby is. It's so exciting. And then it's one of those Lion King moments, isn't it? And we do have surgeons in theatre as well as us as midwives who will give you your baby, or in some cases just hold your baby up.
Just let us know that's what you want to do.
Yeah, so that you can reveal the gender of your baby yourselves. And that's such a lovely moment to see that. And for partners still to be able to cut the cord. In theatre, it's a little bit more difficult. The doctor will cut the cord, but leave the cord quite long so that the partners, if they wish, can still trim the cord down.
Yeah. And we make sure you come over to that resuscitaire as soon as possible to see your baby and be with them in those first moments until we get them back to mum. So we do think about these things a lot.
Yeah, definitely. It's always our priority.
Yeah.